the outcome, because it's supposed to be perfect. You're buying eggs, it should be a perfect outcome. But then can the
Yes.
sperm be a problem? And then that's hard now to the both couple. I mean, it was hard already on one side, and now you have both. And that is something like, how come no one told us or this? And it was rare, but we have seen it where they, again, you're stumbling into it. Come on, there's so many facets of fertility that you cannot really truly see it until you try it.
From the Building Your Family community, this is the Building Your Family podcast. I'm your host, Lisa Schumann, author, researcher, and reproductive medicine therapist. As the leading destination for support and education for people using reproductive medicine to grow their families, we cut through the noise to provide you with research-based information, effective and actionable strategies, and the support you need to empower you to get into the driver's seat of your life and build the family of your dreams. We look forward to seeing you inside. Welcome to our new episode. Thank you for coming back. Today, I'm going to introduce you to someone special. Her name is Dr. Janelle Luk. And although she has a very impressive resume, she's gone to all Ivy League schools and even did her residency at Harvard, which is really impressive. Her life has not been exactly traditional at her practice called Generation Next Fertility in New York. She really is very focused on patient-centered care. And that's what we're going to talk about today, giving patients their autonomy to be able to make the choices that they want to make in their process, and also be able to see a whole range of reproductive possibilities when sometimes we only see a few. So thank you so much, Dr. Luk, for joining us. I really appreciate you being here.
Lisa, and thank you for inviting me. This is really amazing opportunity, and I'm grateful for your invitation.
Well, it's great to have you. And we've been working together for a lot of years. I know you opened your practice in 2017, and it's been a pleasure to work with you and your team. And it's been a pleasure to see your patients come to you from all walks of life. I know that you see a lot of patients who maybe are at advanced maternal age or have some other issues where they're really difficult to treat. And I see how you really try to figure out the best ways for them to be able to find the path to parenthood that they really want.
Absolutely. It is a very difficult journey. It is always stressful for our patients. No one say coming to me is relaxing, which is already hard because now you're trying to take care of a patients who struggle with really a thought that was supposed to be simple and natural, but it's difficult for herself or her partner to have a family because it's supposed to be natural for people, just have time to have intercourse and have a baby.
Mm-hmm.
Fertility is like a stumbling kind of action that you get to for infertility. You don't know you're infertile until you're trying. So as a result of that, then most patients come to us didn't know they would get into this problem. And one can
Yes.
say, well, you didn't know about heart disease, someone didn't know about cancer, they stumble into it. But fertility needs effort from a patient and one's partner or family to plan it. So when they
Yes.
plan, they don't plan for failure, they plan for success. And when you
Yes.
plan for success and you have this unexpected failure, that is what get people. Because then you don't want to plan for failure. No one wants to plan for failure. When you get on the plane, you plan to go on the destination. Okay, you don't plan
Mm-hmm.
what happened if the plane turn around or the plane accident. No one planned for that. So I think that is what is really hard for patients.
Yes, it's so hard. And speaking of that, I see how you're so careful about really understanding patient preferences. And I think that's so valuable because patients certainly have different preferences, and we all work in an environment that's science-based, and we all believe in the research and we love the research. And yet sometimes we have to be flexible about what patients want, even though maybe it is not in their best interest. Maybe people need a closure cycle, or maybe they're not eager to go from IUI to IVF or to go to donor eggs. And so I know that you see these patients who are really struggling and have maybe these opinions about their own journey that maybe not be science-based. Maybe they've been to lots of places that say, well, you have to do it a certain way, and they don't want to do it that way. And you need to individualize all of their care. How do you make those decisions, Dr. Luk? Because it's so difficult.
I'm glad, no one ever introduced the way you introduced me. I think that was very meaningful and the way you did it. You said I'm from a very traditional training background, which is true. I'm from great universities and great training program. But no one really taught me something called natural cycles or mild cycles. That was only from the way I practice, the way I expose to patients, and that how I modify the way how I treat the patient. So even though I have this traditional background, which allowed me, possible with the education and training, allowed me to think outside the box. And my second half of my career is really learning how to think outside the box, of course, with the training behind me and education behind it, to understand is outside the box good, bad, dangerous, safe? What are the ways to see different way of stimulating a patient, or what kind of patient is susceptible for this stimulation has been so tremendously helpful for me because it
Mm,
turns out not everyone have one size fit all, especially for stimulation for patients. And this is where the data is very hard to prove it because some people say, well, it's your third cycle, you make some changes. Doesn't mean your changes make that third cycle great. Maybe it's her third cycle. There's lots of traditional doctors or people be a scientist, and it will. How do you know that? Because of that, can prove in your different protocol can work. I mean, obviously, patient feel that work because it worked.
mhm,
uh, but that is very interesting, and then yes, have I changed it? It didn't work, of course. But then what worse than the first time it didn't work already? You cannot go worse than the first time. So these are the things that we do a lot with patients and really trying to find out certain stimulation. But a couple of types of patient that really, really great for natural and mild stimulation are patient with diminished ovarian reserve from severe to
mhm.
mild diminished, because it doesn't have to be severe, only one egg. Each cycle, you may have 4 eggs or 5 eggs. So that type of patients are very important to us, where we have less medication, and because more medication actually can do harm. So there are some patients you should never do traditional cycles, which discovered.
Mm,
There's the heavy mild stimulation that we kind of focus and individualize for them. And then there's the advancement of terminal age patients, where we know as you get older, you will get to diminished ovarian reserve. I mean, a reality is a better perspective. And some doctors don't see it this way. They're like, well, you're older, so you are less eggs. But to a woman, they don't, not that they don't see the
mhm.
age, but they see the eggs is less. They don't think about they're
Yes.
older. So they also have a different response to stimulation. So I think those three groups of patients are very good in, or patient who had traditional IVF but failed. Means they keep on stimulating the same way in the same way and just didn't get to what they want. And you don't have to switch to mild. You just have to switch to a different type of stimulation. What type of stimulation? We use different oral stimulation. We use combination with some shots. We use some ECG trigger, because now we do mild stimulation. We can allow use a different types of trigger. So there are lots of ways to play around with a patient's kind of cycle and to tweak it to the point where it is specifically suitable for patient's ovaries and patient's body.
Mm,
And people, in the old times, the traditional world of fertility, and I try to get that sense out too, because the medication is also can create some side effects. And in the past, lots of fertility doctors, oh, just take it. Or the oil shots, progesterone oil shots is bad. From
yes,
doctors upgrading wells and allergic reactions, painful. I bet some of the audience
yes.
who have done those medications, and then we try, not that we ignore it, we just like, oh, it just sucks. So,
Yeah,
like that's it.
yeah,
I mean, what can you do? And then
right.
I
Nothing
cannot
you could do.
stop. And also some stimulation medication. Oh, Dr. Luk, it was really, I didn't like the reaction for him. And I'm trying to more cater to that. It's hard. Certain times I'm like, you need it. You have to have it. Or I modify some substitutes or do an alternative. The progesterone oil is always hard because it was data that supported. But now I'm trying to say, if you really feel bad, we can do it every other day. Like we try to have alternative to the patients. But yes, you have to listen to their body. So in addition to customize, for us to do a great customization, you have to do great listening
That's incredible.
and diagnosing from history, which is all the IVF cycle that was done, that you have to go through the cycles and talk to the patients. So that is the kind of the detective part. And then try to
Yes.
give a good regimen back to the patient.
So you really need to balance the science and the personality too, right? Because some patients, we talk very often, let's say in third party, some people will very quickly take their doctor's recommendation to go to donor egg or to surrogacy when they see evidence that maybe they need it, and other patients don't want to. They feel they hold on so tightly to using their own gametes or their own uterus, and they don't want to do it. And so, how do you balance that when you see patients?
The way to really balance like the needs of, first of all, I said the word needs or the wants of having a third party is not easy, because I discover it has lots of psychological, from the partner, either male or
Hmm.
female, to the patient who's and how they both come up with the idea. Because we have so happening to see the wife may not want to, may not resistant to the idea, and the husband's, I'm ready, let's get donor egg and have a child. And even that statement, they may have done it at home already before they even come to me at the office and telling me that. It's very hurtful, right, to
Hmm.
a patient who is already struggling and truly believe that she can use her own eggs. That I've seen where I try to give as much space, making them to understand. Yes, when I sent to you, Lisa, because now it's like couples discussion, and to understand the feelings, and to really go into something deeper, because infertility can be a symptom of many things in life. It can be about one's life work, one's scheduling, and because fertility is a dream of having a family, or the hope of having a more children, or have a child. It has lots of interesting meaning for every couple. I know
Yes.
you're like, Doctor, I thought everyone just want a baby. It's not true.
Hmm.
It's not
Hmm.
true. And Lisa, I would love to hear from you. I mean, some
Hmm.
people want a baby to fix a marriage.
Yes.
Some people want a baby because their parents is asking, both the mom and
Right.
the, well, cultural reasons. I've seen.
Yes.
I'm personally, Chinese, so I have some Chinese couples say the in-laws asking me to have a child. I was like, huh?
Right.
But she would always quote, like, in the whole interview. Never hear it
Hmm.
coming from her. It would be, I'll be like, okay, but what do you want? And then
Hmm.
I hate the
Hmm.
drugs. I'm like, okay, maybe, why are we here? Why did you try? Or there were certain things that crack during relationship. They want to fix the relationship. I've seen so
Hmm.
many different
Yes. So
kind
many
of, like,
scenarios.
it's not the disease, basically it's a symptom.
Yes.
And I mean, at the end, everyone can. My job is here as a helper and coach. I'm not here to find the real cause, and it's not justified because you do it. Everything is justified because it's the patient coming to you and asking for a need, and I will be here for him or her. But when there are problems during the process,
Yes.
that's when they will start, like, they don't then they take really hard, like, because if you don't know the disease, you keep on just treating the symptom, which is, okay, I would do IVF, or I would do this to have a baby. But then when the things didn't go along as was wish, or just buy donor egg, or just then there's more, then the snowball keep on going.
Yes.
And
Yes.
then, or something happened that woke up everyone, it stopped, nature knew, or something, that this was
Hmm.
not. And I've seen many different ways, and yes, even the success, then I see the aftermath, the trauma of the pregnancy. Or so I think understanding a couple of the whys
Hmm.
is so important in the process. But this is also a very personal journey, because they're coming to you
Yes.
say, I'm going for the how. Give me a baby. I'm not here asking you to diagnose me why am I having one a child. And it really is no, it's not there's no place for me, but I do watch out, as in understanding the logic and reasoning. I have a patient coming for egg freezing, and many times I would say, what's your plan?
Yes.
Why you
Yes.
egg freeze? Oh, I just want freeze. I was like, okay. I'm having a baby. I'm going to attempt later this year. I was like, okay, wait, you're 29. You're attempting with your partner. Why not have sex? Like, what is the reason? But then she has a plan. She said, Dr. Luke, I'm ending my job. So where the logic comes, oh, okay. Because my job is to present all the options. Logical or
Yes.
not logical is a matter of perspective. Because she may, her logic is that I want to freeze the eggs for my third child and fourth child. I want to know I have something that give me a sense of
Right.
security. Oh, well, that makes sense. I haven't tried. I only want one child. I want to freeze my eggs. I'm attempting. I'm like, why? You're 29. If you're
Hmm.
not, you
Hmm.
want to do it next year. Why freeze eggs? Freeze with your partner. So those are my job is to understand their logic and reasoning, and their and then my job is to help them wherever it is, because everyone has their own reasoning. So to get back to the third party, same thing. I think at the end is them discovering it, because there are many moments I would just delegate and very clearly tell them the hows, like detail. This is one, two, three, and four. And then they will go home, think about it, and they will come at me with some questions, which is great because the questions review their logic and understanding.
Yes.
Then there may be more emotional journey. They may even come to you by that time, Lisa, and then
Yes.
discover they actually don't want any of this. I've seen patients after a year of moaning about it, they're like, thank you, Dr. Luke, we're in peace. We're at peace. Oh, thank you. This is not what meant for me and my partner.
Right.
So I think that is where the important part is.
So that's fascinating. So what you're really saying is that, you're appreciating that everybody's journey is different. And I think that's, in my experience, has been so true. I see some people who really manage their treatment one step at a time and they move along the continuum, and other people really get stuck. Like, I really need to use my eggs, or I really need to carry, or whatever they feel stuck about. And it's hard for them to get to the next step. And it sounds like what you're saying is that you give them these options. Once you know what their desires are, you give them all their options. But the idea really for you is really to understand what is in their heart, what they're really looking for.
Correct. Correct.
Yeah.
Lisa, it is such a hard journey. The
Yes.
fact that you come in, to have your own child, your own eggs, or and then to tell a individual, hey, it may not be. And then, very rare, but we do see cases where the sperm, it turns out it's the egg and the sperm, where Dr.
Hmm.
Hay will be. One day, a doctor will talk to you a little bit. His third party. We hear lots of things because we encounter different issues with different departments. Third
Yes.
party would be more like getting consents, getting this, and then or the outcome, because it's supposed to be perfect. You're buying eggs; it should be a perfect outcome. But then can the
Yes.
sperm be a problem? And then that's hard now to the both couple. I mean, it was hard already on one side, and now you have both. And that is something like, how come no one told us, or this? And it was rare, but we have seen it where they, again, you're stumbling into it. Come on, there are so many facets of fertility that you cannot really truly see it until you try it.
Hmm.
And that is some of the hardest part, I think, about fertility.
Yes. Yes. Absolutely. Imagine your beautiful future. You're snuggling with your child. You feel so connected to them. Your friends and family are so happy, and you have everything that you've ever wanted. I want this for you too, but I want more than that. I want you to feel secure knowing that you've made the best decisions, not just short term, but long term for your future family. Wherever you are on your journey, whether you're choosing a donor, choosing a clinic, learning how to talk to your donor conceived child about their origins, all of these decisions will have wider implications for your future. And I want you to have the right resources so you can feel empowered and confident at this very important time in your life. That's why I'm so excited to introduce you to Building Your Family. It's the only expert-guided platform designed for parents and parents-to-be using reproductive medicine. We provide unique strategies that you won't find anywhere else to make your path to parenthood smoother and more informed. And that's why our approach is about offering practical and actionable steps that you can use right now. Whether you're just starting out or already deep into your process, Building Your Family is here to guide you with expert advice, specialized education, stress reduction strategies, and a community to support you every step of the way. We can't wait to see you inside. And then what do you do with patients who have this agenda, right? Because, for all of you out there, we're in the New York area, and New York patients tend to be kind of overeducated in this department. Sometimes they come to their doctor's office with a lot of information. They say, I want PGT, I want this, I want that, I want the other thing. Is that overwhelming for you because you're on one hand really trying to give the patients their own autonomy and let them chart their own path? On the other hand, you may have your own feelings about whether or not they should be spending money on all these extra treatments or not.
Yes. I think I was just talking to a patient with irregular cycles. So it's very difficult for her she's PCOS patient. So she can cycle regularly. And for patients that's very easy to have sex, like something so natural,
Yeah.
To us, we never like, where's my period?
Mhm.
People who are, which is difficult because people are having home, having sex, trying to have a baby. She, every moment she wants to have a baby, she just comes through this office, take some medication, do the tracking of her ovulation. And it was a very hard balance for her, like how active she should do with this versus IVF. Because IVF is maybe 3 more visits, but the timing with electros or IUI, there's already like maybe already, 2, 3 visits, sometimes more, especially if you don't
Yes.
respond to the medication. So now suddenly a simple IUI can be 6 visits for 2 months span or 45 days span, even we're shortened from the 80-day cycle to a 45-day cycle. So she was struggling to understand, should we move on to, but then she doesn't want IVF. She was like, Dr. Luk, so it was funny. We were preparing for IVF. At the last moment, she's like, I actually don't want any IVF. I would like
Wow.
to do, and she has been doing the time intercourse with her OB/GYN. But usually with women with OB/GYN, they don't track every 1 week. Are you cycling? Are you ovulating?
Right.
So she was also quote unquote lost. But now without loss, you're coming more training. So I mean more monitoring. So
Yes.
it was great. I try to fit myself into their lives. She was fasting this month for Ramadan. She's going
Mhm.
away to visit her family. So they give her some cushion to take a deep breath. So I said,
Mhm.
no problem. Let's do one more IUI. She was able to do IUI. She said and so that's how we kind of gave her all the choices because she know this.
Mm.
And Lisa, that's not my. I mean, I know I have lots of fancy degrees behind me, but it's like sex, IUI, IVF.
Right,
That's it.
right. Yeah, those are your choices.
Those are choices. So she did the sack. She now won a couple. I'm good. I mean, I don't think it's just pretty young, like under 35. So couple more months of this, it's not going to change. Like March IVF versus September is not make a big
Mhm.
difference. So, or even now she's not saying it's just 2 months from now. So that takes a little bit time for her realization because it
Mhm.
was like jumping in, we're moving towards, but because of authorization, insurance that bought her some time to realize maybe there's not the right moment, and they change. Fertility is a big change in one's life, and each
Yes.
month they do have different kind of thinking, different understanding. The stress, the journey a woman is going through is also changing. Makes them sometimes make different decisions that was tolerable for her 2 months ago may not be something she can tolerate anymore. She wants to get this over with. So then IVF ultimately possible is the choice because coming here, taking letrozole is lots of visits.
It's a lot of visits.
Yes, with a
Yes.
PCOS, I'm talking about for audience
Yeah,
may not
yeah.
understand. Sometimes
Right.
you don't respond, you have to take another 5-day pill, and then before we, yeah.
Right, so there's a lot involved. And what about on the other end? Because I know you see a lot of patients who are at, advanced maternal age. I know everyone hates that term, but at advanced maternal age where their eggs are getting a little bit older, there are fewer good eggs left in the tank. And so here they are, probably gone to a lot of fertility clinics who said, donor egg, donor egg, donor egg. And maybe the patient says, I'm not ready for that. Can we try again? And then you have to kind of balance this. Well, I want to give this patient a choice. On the other hand, donor egg may be an option for them at some point. So, how do you approach that problem solving process?
That is the where natural and mild stimulation comes in. I do worry. I mean, lots of data done because how many times you can do IVF, what are the chances, and we were about cancer. Is there any linkage IVF and cancer? And lots of data say no, there's no breast cancer and IVF cycles. But I don't know. It's just as if maybe the east and west thinking is maybe more meds may not be great for some patients. Only can get 2 or 3 eggs already. So only. So then I will use a little bit less medication, and then I usually have a heart to heart conversation because lucky and not lucky, not that not lucky. Actually, I should say very lucky of me when Genix first started was on patients who have failed at other centers. And we luckily, due to different style of stimulation or whatever the reason, see, I'm being very fair. I don't think it's just me or that
Mhm.
we got them pregnant. And it's all on my Good Luck Luke podcast that they're not actors. They're all patients, real patients that came in. Many, many tries. And everyone on there, they say it's worth it. But it was also selective group of patients, not for everyone. But these patients wanted it; they're determined to have it. They want to, and then we go for it. Then I would give them, and yes, you see the winners. So what about the losings? Do you the people? And obviously, I don't get everyone who is 45, 44, for once a child get pregnant. I want to be very clear in my appointment first time when we meet,
Hmm.
and then we usually decipher out a plan. How many more? Where are we going? 2025. And then she said, well, I want to do this before 2020, so they have
Yes.
more decision and things to talk about and understanding. And so that's when 2020, then I'll say, okay, after, November, and usually they follow their own schedule
Hmm.
because of the limits in terms of finance, in terms of feelings. They follow, they was, and I think that is where they give a sense of empowerment, a sense of control. So I usually decipher our plan with them first, understand that we're on the same page. They will
I
also,
see.
some of them play by ear. They will say, I don't know how I would feel in 3 months, Dr. Luke. And I want to,
Hmm.
so during the journey, I will look at things and make sure that we don't, overdo it or underdo it.
Hmm.
But at the end, it's the patient who come into it, the conclusion, say thank you. So the few patients I had to say stop, very few in my more than a decade career now. So there will be one or two that will be like, may not be great, So it's just, but then most of the time it's them coming to me and say, Luke, thanks. And I'll be like, and I don't get encouraged. So there's never either way. I don't discourage or encourage. Usually it's
Hmm.
patient who is guiding. And my discouragement is when I'm like, yo, not that great. You had history of breast cancer. I would try to breast cancer or family history, certain things. And I'm like, this is going to be a 15th cycle. I think maybe where we have a finite stop. Those are the things that we
Hmm.
talk. And then the patient say, I don't
That's great.
care. And this is really what I want to do. And this is where very few, but most people, again, it's very few for me to have a stop and then it's like fight, disagreement, and you find another oncologist and primary care, everyone just is very, most of the time it's from the patient. Either way,
I
I
see.
want one more cycle, I want no more cycles. It's all from the patients. I'm like the cheerleader. They're like,
Yes.
the little, yeah.
So basically, your idea is that you bring the patients in, you let them chart their own path to some degree, and they come to it themselves.
Yes, and I will try to help them to lead. There are many ways to help someone to lead to the conclusion
Hmm.
because, and they know, but it's something in their heart, and this is where the heart and the
Yes.
voice is
Yes.
that they can't. If something is in one's heart, that is even on the podcast, how do they keep on going? She's, I just want it so much. Like I want to hear what is their voice telling them. I mean, at the end, they got a baby. And then there's
Yes.
also a voice, but after one or two or three more, they will have a voice. Either it's going
Mm.
for it or not going for it. And I truly believe that at the end is that voice, the treatment of the heart becomes, and fertility, just not just making decision like this, but is really majority of fertility.
Yeah.
How you come to that decision, how do you come with that? The symptom versus disease. Why are you wanting this? Then you go to the back to the why. So the why is not why I think important even you have success or failures, but the why is so crucial because problems will come later. Like if you success, problems will still come later if your why is not correct. Let's say
Right.
it's a
Right.
couple
It
who
has
wants
to
to
ma
fix their marriage. It will come back to a couple. And
always come
I've seen
back.
it.
Yeah.
People who divorce and now they're fighting on the embryo remain.
Yes.
So the why is like
Needs to be clarified.
either
Yeah.
way is so important. So I do think, and the why is part of inside because no one knows that part of history. The why sometimes is usually hidden. Usually
Yes.
is from, they may not review. It's not part of family history. They're not going to tell you I'm
Right.
having
Right.
fights
They're
with
not
my,
sharing that.
or they don't even realize. They're not realize the why. Why can be very quiet. Is take Lisa Schumann, Dr. Schumann,
Yeah.
to come to a session. I
Yeah.
bet you don't get to a why until maybe a couple of sessions to get there. Some of them
Yeah.
they just present you what they want to present you, or what they want to say, or what they think they know. It's not even want. They just subconsciously just tell you what.
Right.
It's like people. If you
Yes.
ask me something, what do you want to eat for breakfast? Oh, I ate an egg, but that may not tell you I ate 3 cups of coffee, right? Because
Right.
that sounds
Exactly.
bad. That sounds
Right.
horrible.
It's
You
so
know,
true.
but I
Hmm.
did subconscious. I didn't drink. I don't drink coffee, but I'm.
Yeah.
Subconsciously you will do, yeah, subconscious.
Right. And that comes out.
So I think the subconscious mind is so important. And I think patients do realize it. Lots of our patients amazing, high awareness and insight of where they're coming from, why they're here. And most
Yes.
of them, 80-90% do know. And I think to answer your question, third party, it's usually they know.
Interesting.
Never would be like, wow, why did I do it? They have a decision. I think it's the impasse where before they get to that decision is where the difficult part.
Yeah, I agree. That's so interesting. And I have one other question for you about that. How do you feel about the patients who come in and say, I'd like to transfer mosaic embryos because that's what they want to do?
The mosaic embryos I actually just counseled a patient was an extra. So mosaic embryos, low mosaic, and lots of data has been done, and big paper from a couple of the PGTA companies has demonstrated that the low mosaic embryos actually have the same success rate. Depends on your age group. The in terms of success is always go with age, but the younger you are, low mosaic actually have a very good success rate. I should say not as good, a very good
Mhm.
success rate. I don't want to quote because I don't have exactly, but like a euploid maybe 50 or 60%, and mosaic maybe as high as 40 or 50%. So and to have a healthy child, not just mosaic transfer, have a live birth. So low mosaic is a technology, I think is an inadequacy of technology, where they label it low mosaic because there's a variability within. So what's mosaic, to explain to your audience, is that
Mhm.
we extract egg cells. Blastocyst is only around 100 cells. So you have egg cell that's being extracted is a representation of what 100 cell is. And inside the 8 cells that they target for the biopsy, inside within that, they don't have a consistency, or there's some percentage of cell that does not demonstrate its normal embryo. And that
Yes.
means 46 chromosomes. So there's only 8. So there may be 6 is normal and the 2 cells are not. And they will multiply in the lab and in the PGTA lab. And now they will come back with reports. Well, 20% of the DNA is not normal. They come with that.
Well, it's not a perfect science, right?
It's not perfect science. There's variability. Nature is not perfect. There's lots of shades of gray before you go from black and white, and life is not black and white. We all know from
Right.
anything, anxiety. I
Right.
bet you have major, mild depression,
Yes.
right? For your
Yes.
field,
Right.
for the
Right.
severe fertility, but like everything is like
Right.
there's
But it's
shades of
hard
spec.
because the embryo assessment is a pass fail system.
That's
So,
right. So then you have
yeah.
this now technology is also not perfect. They just beep beep, So you can argue with the lab technician. You guys should have mosaic being, totally clear, good. Why are you giving a report from us? So there's also imperfection of technology, and where's what they bring the line. So you have beep beep, good. How, and that's what, and that's why low mosaic, the line I think will change. Means that within the machine they may not call it low mosaic. Eventually, in a
Mhm.
couple of years, they call it normal because they have seen so many normal from those low mosaic. That's why they keep on collecting data to understand that, because you need live birth rate, the clinical results to justify that machine also in so many ways, right?
Right. But patients get nervous, right?
So now you have a mosaic patient get nervous. If it is untested, you may have been a child already and no one talk about
Yes.
it. So I have a patient who has a XY embryo we were just talking about yesterday. But the mosaic was a positive extra 21 chromosome, which means the
Uh-huh.
embryo can be a Down syndrome. So now, if this embryo chromosome is trisomy 8, not that we don't care, if you Google trisomy, is a big deal. Okay, so if you just Google trisomy A or anything that's not involving Down syndrome or anything, it sounds very bad, but most of the time it doesn't implant. Okay, so
Yes.
but we're doctors, we go by the books. So now you have a trisomy. Let's say this one's trisomy 21, which is already scary. But let's say you have a
Yes.
chromosome that's trisomy 8. We have had transfer that because we tell patient majority of the time you're not, and geneticists will obviously lots of counseling and basically will not stick anyway. How do you know, Dr. Lu? Actually, I've transferred lots of abnormal embryos because before PGA time, I was already practicing, not to the
Right.
younger doctors.
Exactly.
But when I was a fellow, I didn't, many embryos was not tested.
Yeah. We had no blastocysts.
But obviously, there's not many abnormal individual in the world because embryos do
Yeah.
not stick when it's not good. Because ultimately, at the end, with all this technology, with the humble to nature and yes, to religion will be God, that is that they select the embryo. Because if
Yes.
it's the embryo, the best embryo I put in, I say is euploid and normal grading. We have where we like throwing hands the perfect uterus. Why it didn't stick? I
Yes.
mean, we have this every week and many,
It's not a perfect
not
science.
frequently, but it happens with all of us doctors. So I think that normal embryo or mosaic embryos, it has to come with a good understanding. When we say normal, and I think there's a deceiving term, it's a screened, not Down syndrome embryo, genetically intact of 46, and there's some limit with certain platform. Some of them are 69 chromosome. The multiples of 23, some platform we missed. Right now, Jen is doing a platform we should not miss multiples of 23s. I know, isn't it
Mhm.
crazy? So if it's a extra 2 chromosome 48, you will not miss, but you will miss 69. And I know to you, it's like, that's still not 46. I know, but to the machine, because of the technology they have, is the normal embryo.
Mm.
Going to elaborate more, sorry. So the mosaic embryo, I usually, for this patient who has a extra, it was a very difficult decision, and patient likely would not transfer because the possibility that this embryo can be a Down syndrome is there. And the only
Yes.
last thing we want is not stick, is not as traumatic as having a Down syndrome, and you have to make decisions as we implanted the embryo.
Yes.
So because of that, this is, even though it is not mosaic, it's a mosaic 21, that make us not want to transfer. So to answer your question, with low mosaic does not involve some of the chromosome life forms. Sex chromosome can have a life form, 13, 18, 21, and there are many others. I'm not going to alter you. Then we will defer not, well, conscientious decision. I have a patient, one XXY chromosome is fine for her. She will get a genetic counseling, because this patient's rights, what they want to do with the
Yes.
embryo, even though it's maybe gender chromosome abnormality or certain. So I think it is not again, one stone hit two, everyone, not one size, sorry, I mean, one size fit all. Everyone,
Yes.
even mosaic embryo, has lots of discussion with different couples. And this particular patient actually did already have a normal, had a euploid normal embryo from us, and had a baby. And so now she just wanted a different gender. And so this
Mm.
specific embryo has it's hard for them to, conceptualize it at the beginning, but they are, but that is a discussion. I didn't
Yes.
say, she asked, I never say no to, but at the same time, I say what I'm really worried most, because if this happened to me as my partner, we don't want an embryo or Down syndrome, or have the possibility of it,
Yes.
and how much you tolerate. Some people tolerate 10% risk, some people tolerate 1%, literally.
Right.
1 and 10% to a couple is very different. To me, it's
Yes.
about the same. But to some people, or 20 and 1. So
Right.
I think those are all decisions, but low mosaic embryos, however, and also to a PGTA community right now, is very controversial, because, like I said, untested embryo, and now we did decrease miscarriage. Want to PGTA is not like totally useless. I don't want to go to another extreme. It did improve success rate in patients who are over than 38. But yes, some centers now say it's the same as tested, and when patient want to save money, or some patients are doing untested embryo at a younger age, because it's stake with stake.
And some patients only have that choice, right? Some patients may only have 2 mosaic embryos and they say, "I wanna try," right? That's all
Yes,
I've got left, and I'm
yes.
40
And I
something
did
years
have
old, and
that during COVID time, and I transferred 2 mosaic embryo from different. And mosaic now is more talked about because PGAD
yes.
is more challenged recently in the last couple of years.
Yeah.
But she had to transfer the mosaic to my office for me, and she had twins, because we thought it was her last transfer. She only had coverage for her last. So and we thought it was not going to make it. It would not stick. Two
There you
healthy
go.
children. That we go. She moved
Wonderful.
to Connecticut. So
Yeah.
but yeah, lots of
We lose
counseling, lots
some.
of understanding,
Yes.
and sometimes just a, like, you jump for it, which do you take the risk or you don't take the
Yeah.
risk? So
Yeah. Well, I think that's a great place for us to wind down, Dr. Luk. Thank you so much. I think this is really helpful information for everyone out there to understand that there are a lot of choices, even though the science is kind of driving our industry every day. There are a lot of choices, and everybody, as Dr. Luk says, has the right to their own autonomy and their own feelings about what's right for them. And it's so nice that you really give patients that opportunity to think through these things. So thank you for joining us today.
thank you so much, Lisa, for the amazing invitation, insightful questions. I really truly enjoyed the conversation.
Oh, you're welcome. And where can people reach you, Dr. Luke?
Actually, my name, Dr. Janelle Luk, on the internet, or Good Luck Luke, my handle, Generation Next Fertility.com, and that you can reach me in all
Everywhere.
everywhere.
Terrific. All right. Well, thank you. And thank you, everyone, for coming. I really appreciate your time. And please press subscribe so that we can keep going. That's how we keep going. And I look forward to seeing you next week. Hi, it's Lisa Schumann. I hope that you enjoyed that video and I hope it helped you. And if it did, please give us a thumbs up and subscribe because that's how we keep going. It's really important to us. And if you liked it, you might like this one.